Good afternoon, everybody, or good morning. Welcome to this webinar about research and anti-corruption efforts. At WHO, one of our key priorities is work towards universal health coverage. And as a health agency, we are not necessarily concerned about corruption per se, but we are concerned about how corruption impacts on countries' abilities to govern their health systems, to deliver vaccines and medical products, and to deliver health services. So we are delighted today to have a range of excellent speakers who are going to be able to talk to us about health system corruption, why it's important, and why we need to do a different approach to research to health system corruption so we can better understand the impact of corruption on health systems and on the health system goals that we all share, including the goal of universal health coverage. We have an excellent panel of speakers today who are going to speak about their work in practical contexts to better understand how corruption impacts on health systems, and to talk about how we can refine and refocus the research agenda so we can better understand the corruption issue and how we can address it. So without further ado, I will pass over to our first speaker from Nigeria. We have Obina Onowiki. I'm sorry if I mispronounced your name, Obina. But would you, Obi? So over to you for your presentation. I have your slides on my laptop. So if you just tell me when you want me to change to the next slide.
Okay, so thank you very much. I'll be talking on the Nigerian case study, understanding priorities for policymakers and corruption research and study. So second slide on the methods. So to undertake this study, we use the judicial review and the nominal group technique. So we first did a systematic review of literature, focusing on corruption in health system in Nigeria. And then we reviewed 50 publications fully. And then we also undertook a nominal group technique with 30 participants. These participants were frontline health workers, who interact with patients at that level. So the NGT participants they identified corrupt practices at the primary health care level, and they ranked them in terms of importance, and then also in terms of feasibility of addressing those corrupt practices. Next slide, please. So the NGT as a nominal group technique, there were 26 senior healthcare, that first one, and then after ranking, we now presented what the health workers ranked to senior healthcare managers, to see whether, both from the view of the health workers and the managers, when there was a convergence on ideas on corrupt practices and how to address them. And then part of what we did was also to discuss how each of the 5 top corruption concerns can be addressed using, the usual top-down methods and also the horizontal methods, which are things that can be developed and implemented at the level of the communities and primary health care level without having to come from the national level. So that's what we mean by the horizontal. Next slide, please. On the planning. So the participants identified 49 different types of corruption at the primary health care level. But we then condensed the 49 because some of them were overlapping. So we condensed the 49 types of corruption into 19 types. So there were basically 19 major types of corrupt practices at the primary health care level. And then the participants were now asked to rank them. So they now ranked, and they got the 5 top corrupt practices and scores. And then after discussing about feasibility on how to address the 5 corrupt practices, they were now ranked. So that's what we now chose as the final ranking of top 5 corrupt practices. So next slide, please. So if you look at literature, findings on literature, well, we identified top, from different types of literature, top corrupt practices on literature. They include like sale of public positions, procurement, corruption, absenteeism, door practices, informal payments, hospital detention practices. So there are so many of them which were identified as priorities. I think I would like to pay more attention on what we got from the terminal group technique. Next slide, please. So if you look at the left side, that's the condensed 19 corrupt practices, where absenteeism is number 1. And the last one there is the procurement of illegal drugs, drugs that are not supposed to be within facilities. They're actually procured and kept in facilities. But if you now look at the right side of the table, those are the top 5 corrupt practices that the policymakers could be addressed. So number 1 corrupt practice is absenteeism. Number 2 is informal payments. Number 3, employment-related corruption. Number 4, corruption with health financing at facility level. And then number 5 was procurement-related corruption. So these are the top 5, for policymakers we need to produce more evidence and then for them to be addressed. Well, the next table just continues on the what we got from the 19 condensed corrupt practices. Some of them didn't make it to the top 5, but I think the top 5 is where we're paying more attention right now. So on solutions, next slide, please. On solution, well, there were so many solutions that were suggested by the policymakers.
What do we do? Okay. Look, I'm very sorry, we're having some technical problems reconnecting Obi. So I think we'll try and move on to our next speaker and try and reconnect him. So our next speaker is Eleanor Hutchins from London School of Tropical Medicine and Hygiene. So Eleanor, would you like us to, I can run your slides for you when you are ready to go.
Great. So it's super here really the people Geneva and beyond. What I wanted to do is give a very brief on the work that I do with Dina, Martin, London School of Hygiene, but also with partners in Nigeria, Tanzania, and Bangladesh, and also with SOAS here in London. So what I want to do is focus a little bit on theory, and this is really to say that what we want to do is bring together findings and arguments about corruption and really anti-corruption that's been going on within and beyond health. Think about how we can draw new research into new approaches to anti-corruption action. So this is something that's challenging. It's something that it would be, good to talk about with more partners, which is that, the world of anti-corruption is very challenging, and drawing in new research findings is something that is really very tricky, but extremely important to do. So can we go to slide 1, please? Great. So the starting point of our argument really is that we need to rework theory and we need to rework research frameworks that are currently dominant in health. And in particular, they're dominant in health, they're also dominant beyond health. And these are really good governance frameworks and agency theories. And what we see when we go through these is that they create critical blind spots. And we're not the first people to say this. I think we're unlikely to be the last as well. There's a huge literature on the problem with good governance. But I think we need to go back to this critique and think about it in-house, because good governance and a focus on transparency and accountability without thinking through context, that's the politics and social relationships in which accountability and transparency initiatives are manifest, makes it very difficult for them to be effective. So let's just think quickly, what are the blind spots when we use good governance, when we use agency theory, what are the blind spots that they create? Well, in terms of research, what it means is that we fail very often to consider the complexity and also the fluidity of relationships between actors. Secondly, and this is really critically important, we focus on individuals at the expense of thinking about the social and the political and the economic context in which they're embedded. So context really matters, and in good governance frameworks, very often we lose the context and we need to draw that back in. And related to this is the fact that it also, in these good governance frameworks, we don't think very often about historical trends, about informal norms, and about systems of governance that are already in play. So sometimes when we're using these frameworks, we think about corruption as an absence of any governance or rules at all. And as an anthropologist, I know that there are always systems of rules in place, and we need to know what these are. They may well be informal, but let's never think about corruption as occurring because there aren't any rules and there aren't any norms. So if we have research that focuses very closely on distinct relationships and doesn't allow us to see the context, what does this do then to policy? Well, what it does is it promotes activities across sectors, broad brush, clean governance approaches that are hugely demanding and demand huge social change. And they also promote approaches that fail to consider the position of actors who are expected to act on transparency and accountability interventions. So if you're saying we're going to put interventions in that enable people to see whether health workers are more present at work, that's all very well, but who's going to take up those findings and make demands that health workers perhaps come to work more often, or that informal payments aren't made? We need to think about where people sit in terms of the power structures, which are often informal, to see whether they can really embed these interventions into their health system. Okay, so this is the problem. And then I think what we need to acknowledge is that there's a good deal of important information then that gets left out when you use good governance frameworks. So let's think about what this information is that gets missed out and what we need to incorporate in our anti-corruption policy. So let's move on to the next slide to do this. Okay, so there's a good deal of work that has been done here at London School of Hygiene, but also amongst anthropologists and people working in governance. So I'm thinking about de Sardan's work as an anthropologist and Claudia Camargo's work. She's based in Switzerland. And I think what we see from this work is that when we bring the context into play, is that rule breaking and corruption among many frontline service providers is often part of a much broader social process, a generalized informality. And this comes from informal rules and tacit codes, and these in turn are embedded in historical and social and political and economic logics, as well as more recent local and sectoral dynamics. So these are, rule breaking and corruption are not discrete activities that happen between particular principles and agents, for example, but these are much broader social processes. And in practice then, rather than having corruption happen in a place where there's not enough governance, there aren't enough rules, what we see is actually we have a pluralist system of regulation. So lots of different layers of rules and regulations that dominate in clinics and hospitals. These are both formal, the interaction then between formal and informal norms or systems that go on. And rather than individuals being important in terms of the analysis, what we see is an important focus on networks rather than individuals. These are individuals interacting with groups of other people. And that as these networks function, they're often underpinned by moral codes and kin-based ties, but they can also be formed of more simple social relationships. So looser social ties where people are trading, for example, access to healthcare services with access to educational services. So we have networks and groups of people acting in particular ways. Fourth, and I think this is really critically important, and something that maybe Dina might pick up on, is the fact that corruption is a form of problem solving in many health systems and a means of distributing scarce resources. So when health systems are under stress, you get informal ways of distributing resources, which may impact negatively on people, but it does mean that a certain amount of the job gets done. And I think it's important that when we think about corruption and we think about sort of getting rid of corruption, that we think also about survival corruption when people have no other choice than to break the rules. Because we want to tackle forms of corruption that are not only feasible to tackle, but we want to think about the forms of corruption that act most in terms of sort of undermining universal health coverage, for example. Okay, so there's a good deal of work that we need to incorporate into anti-corruption strategies. But actually, I think one of the questions that people have are, what on earth do we do with all this knowledge about the informal system when we're working with policymakers who only have a formal system to work on? So let's turn to the next slide. Okay, so the next slide then seeks to sort of think about this question. How do we act on these informal processes, these networks, these informal norms, these different rules that are working through health systems? And one of the strategies that we're using then is Mushtaq Khan's idea of developmental governance that you will find in the ACE approach. And what happens here is that good governance approaches, which tend to be quite broad and look at let's have transparency across the health system, shift. And what we have is an approach that looks at much more targeted anti-corruption strategies. And the first thing is that these need to be targeted to high impact areas. So corrupt activities that are having a very negative impact on universal health coverage, for example, would be one. So you look at these high impact areas. And then when you've got your targeted area, you then broaden your questions out and say, okay, what's happening here? What's influencing what's going on? What are the networks that are involved in this? What are the informal norms and rules that are going on? Does this relate in any way to forms of survival corruption? And can we have any inputs into health systems that will be particularly targeted around this? Let's then turn just to the final slide, and we'll think quickly about what you need to think about and what you need to do if you're going to use these targeted, high impact and feasible anti-corruption strategies. First of all, don't generalize. Look for differences in terms of the health system. So we need much more nuanced research. So for example, if you're looking at the health system alone, cadres of health workers may appear homogenous. Junior doctors may appear like a homogenous group. When you start taking political and social networks into account, you'll show that they're differently positioned and that this may pattern their rule-breaking behavior. So for example, junior doctors in Bangladesh may have different access to political networks, and this impacts on whether they're absent or not. And when you understand the differences in this rule, when you understand how these differences pattern rule-breaking behavior and corruption, you can find groups of people that you can work with. For example, you could support novel forms of collective action, support the junior doctors who are in rural health centres in Bangladesh to be able to do their work better, to support them so that they don't have to be involved in forms of sort of survival corruption where they have to be absent in order to seek new positions or seek to further their careers. Second, in terms of supporting novel forms of collective action, there's some work that we're doing, for example, with drug shop vendors in Uganda to find out how it is that drug shop vendors who want to be rule abiding can be helped to do so in a market that's very difficult. So again, we're taking a group that appear to be homogenous and looking at subgroups within that we could work with, that we could pull together to support an anti-corruption intervention. And then finally, and this is really in relation to this idea of survival corruption amongst health workers, we need to target funding at critical problems in the health system so that we can get groups of health workers who really do want to be at work and who would be at work much more often, for example, who don't want to be involved in taking informal payments so that they can continue to survive and make ends meet without having to do so. And then the final slide is just an acknowledgement of everyone who's been involved in thinking through this work. Thank you.
Thanks, Eleanor. That's excellent. So our next presentation is Martin McKee. Martin's a professor of public Health at London School of Tropical Medicine and Hygiene. And Martin's going to talk to us about strengthening accountability to tackle corruption. So I'll just put Martin's slides up, and then we can get on with Martin's presentation.
Sure. Well, the first slide is the title, so we can read that and then move rapidly on. And we're particularly concerned about why we're so reluctant to talk about corruption, because we know that it is a problem, and yet often it doesn't feature in the discourses. It is something that's not really spoken about at the World Health Assembly or at the board of the World Bank, or when ministers come together, they talk about lots of things that their countries are doing. And they often talk about the problems they face, the diseases that are afflicting them, but they don't talk about corruption. Now, there are lots of things that we don't talk about in public, and in a recent paper, which was on the initial slide, in fact, we know that this can change, and a classic example of that is the Me Too movement. Sexual abuse was something that was not spoken about publicly, and exploitation for a long time, and yet we now are beginning to do it, maybe not enough, but we are beginning to do that. This is particularly surprising because we know that health systems are notoriously corrupt. When Transparency International do their surveys, they often find that the health system is the most corrupt sector in a country. And we also know that this matters. We have one study that estimated that corruption contributed to perhaps 140,000 child deaths annually. So the next slide, please. There's another reason why we need to talk about this now, and this is because all of our governments have committed to achieving the SDGs. Now, we're already almost 5 years into this process, and one of the SDGs, SDG 3.8, includes universal health coverage. We have a long way to go, and we're only going to achieve universal health coverage, by which we mean health coverage for everyone, if we can root out corruption. So clearly related to achievement of SDG 3.8, but also the corruption is related to two of the other SDGs, SDG 16, which is about peace, justice and strong institutions. We need to have systems in place to eradicate corruption. And SDG 17, partnerships, because we need people to come together across a range of different sectors to tackle corruption. So the SDGs are should be a driving force behind our efforts to tackle corruption. Next slide, please. I'm going to go through 5 challenges that we face in trying to develop a research agenda on corruption, and I'll go through each of them in turn. Maybe the next slide, just move quickly to it. The first is, how do we define corruption? Because there are a lot of things that go on where, some things are very obvious, some types of bribes are clearly corruption, but others are often, well, it depends what way you're looking at it. Some people might feel that they're corruption and some might not be. First problem is that we have far too many words. Even if we just look in English, we've got backhanders and bribery and exploitation and extortion, fiddling, fraud, graft, jobbery, payola, and so on and so forth. And then we have words in other languages, some of which have gone beyond the original languages, like bakshish in Arabic. And again, that can include corruption, but it may not. It may be sort of begging and all sorts of other things. There'll be a lot of meanings that are attached to that, and they may vary from place to place. And then there are local variants, words that are used in one part of the world, like dash in West Africa, and not in others. So we do have a definition from the Cochrane collaboration: the abuse or complicity in abuse of public or private position, power or authority to benefit oneself, a group, an organisation or others close to oneself, where the benefits may be financial, material or non-material. Now that's great, but of course the challenge then is to operationalise that, and there is still, even with that very comprehensive definition, some room for interpretation. And this can become a problem with things like small gifts. Are they just simply tokens of gratitude, where a grateful patient may leave a box of chocolates and a ward? Would that be corrupt? Well, it would be if they left the keys to a luxury car, but if it's just a packet of biscuits or something, is it? And then what do we do about absenteeism? Some absenteeism is because people, health workers, are away doing something, working as health workers in another facility privately or in another job when they're being paid. Some of them are ill, some of them may have other reasons. Some of them may be just exploiting the sickness benefit arrangements. And so we can get into all sorts of challenges simply with the definitions. Next slide, please. Then the second issue that we need to face is, what do we do if corrupt actions are the only way to make things work? And this is at the heart of the ACE approach, because we know that often people find themselves in a dysfunctional health system, and the only way to keep the system functioning is to do things that might be seen to be, and probably are, corrupt, like giving a present to somebody who's responsible for stocking the pharmacy, or a bribe to get something done. And even if there's a reluctance to do that, the alternative is that the patient does not get treated. We obviously know that accepting bribes is wrong. That's fairly clear. But what about people who offer them? Often they're in a weak and vulnerable position, but they're complicit in corruption. What do we think about the actions that they take? What do we do in a situation where there are informal payments that are being used to keep a facility open and operating, but they're not going into the pockets of the health workers? Well, that could be seen as a form of corruption, but on the other hand, it may be the only way that the health workers find to to be able to treat people. And the question at the end of all of this is that if we do eradicate all of these forms of corruption, large and small, will the system actually stop working? Is it really the case that this is the only way to get things to work? We'll move on to the third, if I may, to the next slide. How do we conduct research on corruption? One of the reasons we talk so little about corruption, we feel, is that there is so little research to draw on. Inevitably, much corrupt behaviour occurs out of sight, hidden from the public, and that means it's hidden from researchers too. Most people, if they know they're being observed, will not engage in corrupt activity, which is why journalists use other sources of information. For example, freedom of information requests for emails and things like that, or covert filming or so on. But some of these may raise questions with the ethics committees that we have to comply with. And that's something that we've addressed quite extensively here at the London School. What is our responsibility when we witness corrupt activities that harm patients? This is similar to the problem that has been faced by those looking at vulnerable people, where healthcare workers are often behaving in a bad way towards them, harming them, hitting them, for example, mistreating them. But do we have a duty to intervene, or do we simply report it and watch and have them held to account subsequently when our papers come out? And how do we really get to the root causes of the problem of corruption? This goes back to the point that I was making about informal payments being used to keep a facility open. Where is the corruption? Is the people who should be held responsible, are they the people in the facility taking the money to keep the facility going? Or is it the ministers, the politicians, who are not providing enough money for the system to work? The next slide, please. And some people would say, and this is becoming less of an issue now, that it's not even legitimate to search corruption. And by this I mean that there is a feeling that many of the problems in health systems are as a result of a neoliberal agenda in which health systems have been squeezed financially. And it links back to the point about people engaging in informal practices simply because it's the only way to make things work. And if we focus our research on them, then we're really blaming the victims. Instead, we should be looking at the people who are responsible for the health system and look upstream. Is there a danger that by focusing on this misbehaviour that we divert attention from the more fundamental power imbalances that we find in society? The final challenge on the next slide is whether we know how do we know what works? And this is we need research if we're going to be able to talk about corruption and what to do. But the problem is that when we look at the systematic reviews, they find remarkably little research on what works to tackle corruption. We can find papers which describe the problem, but they don't tell us what works and in what circumstances. And there are huge challenges in implementing and evaluating interventions, not least because there are a lot of people who don't want you to do them. and also because it may be challenging even to get people to recognize that there is a problem. And then finally, as Eleanor said, one of the big issues is context. Even if we find something that works in one setting, how do we know if it will work in another? And as we have so little research at the minute, it's very difficult to know what are the critical factors for success or applicability. Or, in fact, Eleanor said, don't generalize, but maybe we generalize with some caution. So we can maybe generalize some things, but we do it with very considerable caution. Can we move to the next slide, please? So what do we think can be done? Well, the first thing that we think is important is that we need to talk about this. We need to get corruption on the agenda. We need to convene key stakeholders from throughout the health system, but from beyond as well, from law enforcement, from governance, from other sectors, from education, from finance, and so on. But when we talk, we need to make sure that we're not talking among elites. We need to make sure that we are giving voice to the disempowered, because they are the victims of corruption. Even if they are sometimes the ones that are acting in a corrupt way, the frontline health workers who are taking bribes because it's the only way to feed their families, they are also victims too. We need to talk, but then we need to prioritize action. And again, to reiterate what Eleanor said, we need to focus on what is most important for the health system, and also on what might work. In an ideal world, we would tackle everything, but there is so much to do here that we need to concentrate on where we can get some wins. And we should avoid too easy solutions, and particularly going back to Eleanor's point about not generalizing, we should be careful about taking ideas just because they've worked in one place, because when we apply them to another, they're probably wrong. And the final point is that we need to take a holistic view. We really do need to understand the context, and crucially, we need to work across disciplines. And even here, the three of us together, Dina Balabanova is a health policy expert, Eleanor is an anthropologist, and I'm a physician. And we work with colleagues who, like Obi, you heard from Nigeria, who's an economist. So all of us have different backgrounds. We all come together respecting and drawing on each other's disciplines to tackle what is a very complex problem. And then my final slide just leaves us open for questions. Thanks. Thank you very much.
Thanks, Martin. I think we'll hold questions until we've had the final presentation. But so the next presentation, which is a nice segue into the discussion part of the webinar, is from Dina Balabanova. Dina is going to talk to us about how we should move towards a new research agenda in this area. So I'll just turn on the slides and then we can hear from Dina.
Thank you. Before we move to my talk, and it's a great pleasure to be here today. So I wanted to really emphasize something that was part of Obi's slides, and unfortunately this was cut off, but it is a really important work that Obi and his team have been doing within the ACE program, looking at the different approaches to understanding and tackling corruption, and the different approaches in Nigeria, to be very context specific. So he was looking at various vertical approaches and horizontal approaches. So the traditional approaches to tackling corruption, for example, employment-related corruption in Nigeria, financial flows, corruption related to financial flows or informal payments, have been vertical, which means regulatory. So the authorities up there decide and monitor and try to clamp down on such practices. However, their reach is very limited very often, as we know in low and middle income countries. We heard about networks, we heard about collision. That's not just outside the health system, that's also in the health system, within the health system and within every facility. But there are other approaches which are showing promise, and the work that Obi did and consensus building in Nigeria showed that policymakers are interested. What are the ways that we can get the staff to work together and actually to help each other? We know that, for example, a lot of the nurses reporting having to leave their post to go and be engaged in farming due to their gendered roles. So should we punish them, or should we be flexible about shifts? These are some of the solutions that are coming really importantly. And increasingly, people realize that very few people are intrinsically evil. A lot of people work in health because that's their vocation. But ultimately, they're very often put in a position where they have to break the rules to survive, to provide services, or to fulfill their familiar obligations. So this is, I hope we can have the slides available later. He has listed different interventions which are both horizontal and vertical for different types of corruption. And that was very much generated by the stakeholders in Nigeria. So that's not researcher generated. So moving now to my presentation. I wanted to really talk about what is the research agenda, what are the type of studies and research we need to do, because we heard about a lot of ideas, but we don't have a lot of material, and a lot of the systematic reviews that we did come up with sort of not really sufficient depth to allow us to understand these networks, to go outside the health system. So first of all, I would like to raise a few questions, which I wanted to see whether this is something that resonates with all of you. So first of all, Martin and Eleanor spoke about what is a corruption. I mean, when we see situations where the systems are defective, there are inefficiency in the systems, and people to get things done in their daily practice, they have to break the rules, what Eleanor called survival corruption. Very often that's not individually based. That's something that people do as a team, and this is in order very often to provide any service. So how should we address that? According to the traditional vertical approaches, that should be clamped down, but can we draw the line? Can we think in a more nuanced way about different forms? So another issue which very much has come from our work in the ACE program is really understanding who holds the power. Because if you imagine a health facility, it's a cascade of levels. There are health workers on the front line, and then there are supervisors, and then people at the district level or national level. So there are also power structures, informal power structures in the community. So who are the health workers accountable to? So we don't often know. So we just say, okay, 30% took informal payments. But what is going on? Is it something that's being expected to the community? Are the people who are actually the senior people above them demanding a cut? We don't know often. What are the power configurations? And importantly, according to the ACE approach, the work by Professor Khan, I think the takeaway message is if you want to have an anti-corruption strategy, you need to find somebody who benefits from anti-corruption. So they've done this in research in other sectors where they find that almost saying to for example, to suppliers, if you take the honest approach, you will get the benefits and maybe you get more clients coming to you. So in health, we haven't done this analysis to a large extent. So we are doing this within our program in Tanzania, Nigeria, and Bangladesh. But often these structures are not visible and it's difficult to disentangle them. We really need more research on that. And then what are the social political drivers of corruption that drive individual health seeking? So I was thinking, it strikes me that in order to understand the corruption in the health system, maybe we should not work on corruption in the health system. We should go outside the health system and understand corruption in the local community, corruption in local, say, authorities. So maybe we should understand corruption in education, in other sectors, or in livelihoods. So if people are pressed and they have to really depend on other people, maybe it's not about the health system. So paradoxically, we should think about leaving the health system and understanding what is it that drives corruption from outside. These are some of the questions that I wanted to raise and move to discussion. This is all from me for now. I would love to hear some comments to what we have heard so far.
Thanks, Dina. So now we have around about 15 minutes for comments and discussion. So we'll open the webinar up for people. So to do this, if you could send us a question through the question function on the webinar, and then we will make you a discussant, and then you can pose your question. So just to get things rolling, a question for Dina. Dina, if you were going to advocate for one key area of research to help us address health system corruption, what would that be? What would be your top priority?
Am I unmuted now?
Yes, you're unmuted.
Yes, thank you very much. I guess this was on my next slide, summarizing this, really trying to understand the political drivers of corruption and the informal power structures that influence what we see in the health system. Because I believe we need to think what Eleanor said is the collective drivers of corruption. We think as a very individualistic way, and this is because of some of the definitions. We define corruption, for example, informal payments as transaction between the patient and provider. We don't think about the other people who benefit from that, and that could be other people, for example, other team members who benefit, for example, nurse or various other people involved in the system that benefit from this transaction in a very indirect way. So I think we need to understand this sort of, I would say two things, the political drivers, but also the network and the collective sort of relationship basis that, and move away from the individual determinants of corruption. I guess my colleagues can.
Yeah, I mean, just following on from that, you could argue that governments sometimes benefit from corruption in the form of informal payments because it allows them to say that they are providing a healthcare system, even though they're not. And in fact, the bills are being picked up by somebody else. So it's a benefit in that they can then spend their money on other things, like presidential jets, for example.
And if I can add something, just a very quick, when me and Martin started studying informal payments in the 90s, and one of my first questions was why none of the governments in Eastern Europe and Central Asia has official policy or ways to clamp down on those. Why? And I think what Martin said was very important, that this is a very known practice. The levels were something like 80% of all people seeking care would give, but it was never in any official document because it was this source of funding which the governments wouldn't want to regulate. It was something that kept the system ticking for many years, and including some of the countries that have social insurance systems in the region, they've moved from informal payments to different types of kickbacks. So again, there are additional money coming into the system, maybe not at the same level.
Great, thank you. Thanks for that. Now we have a question from Shazia. We've unmuted you. Would you like to ask a question? Shazia, we see you've got your hand up. Would you like to ask a question? Okay, I can see the question in our link. So this question is to Martin McKee, and it says, do you think that health workers' corrupt behaviours and informal payments are due to problems with insufficient salary packages?
No, I think that in some cases they are, but not always. And in our work in Eastern Europe, we talked about the concept of INXIT, INXIT. And that was normally in a health system, people who are dissatisfied with the system have got either the power to exit it or they have the power of voice, they can complain about it. But in some systems, they actually can't exit because there's nowhere else to go. And even if they say something, nobody will listen, so they effectively don't have voice. So we talked about an informal exit in those systems, and that's often where they pay informally for services that should be available because they're not. And we argued that that had grown up particularly in Eastern Europe because there was an unwillingness to invest in the health sector. The problem is that once you've developed that culture, and I'll use the word culture guardedly here, but once you've developed that set of norms and beliefs, then it can be very difficult to eradicate. And in fact, what we also found was that even when there was a further investment in the health system and resources were available, The informal payments continued, but they also extended into the newly emerging private sector, where people were paying formally anyway for their care, but often they would pay a little bit on top. So partly yes, but it's not the entire explanation.
Thanks, Martin. The next question is an excellent one. In countries where corruption is institutionalized with centralized and imbalanced powers, the questioner wants says that doing research can actually be a very risky activity. How do we go about it? Where can we start?
When we started working on corruption on this particular project, the ACE project, which is in Tanzania, Nigeria, and Bangladesh, we expected a lot of pushback and resistance. And one of the surprises was that that was not the case. People, in some cases, for example, we had to be careful with what wording we use, but there was a lot of willingness, and that was particularly the case in Nigeria, where there is a huge amount of constituencies openly talking about it, and there seem to be a lot of driving forces, even, of course, civil society, but not just that, even within governments, because there was an understanding that in order to progress, in order to develop the system, you cannot stay at this level. You need to do something, either motivate people to change practice, to change what we call cultural relationships, at the same time to sort of move to a more sort of maybe financial protection and all the electronic systems and optimize. So there was a lot of feeling that if you want to make your life easier as a health professional, you don't always benefit from corruption. And we've heard this in many countries where doctors would actually say, I really don't want to be brought perfume or vodka or something, because it is humiliating and it makes your life difficult. Because if the diagnosis is not incorrect of the patient, or if the outcome is not good from the treatment, they can come back and they can tell everybody what happened. So a lot of people in the health systems of many countries don't want corruption, and there is a lot of openness about that. And so that's my
Yeah, and also what it does is it actually, in some ways, in some circumstances, but not in all, it can change the balance of power between the patient and the provider. Because if the patient has the ability to pay or give bribes, then they have relatively more power than the provider. But as Dina said, and in fact from Dina's own work, were many examples in Bulgaria of health professionals getting presents that they really didn't want. And I remember one where a patient was undergoing cancer surgery, and the family organized a party the night before with large amounts of alcohol and so on for the surgical team, which they thought would be, help the surgical team to operate a little bit better. But the surgeons were, first of all, they weren't sure that drinking all that amount of alcohol the night before would be good. And secondly, they wondered what on earth would happen if the patient died, or last year's Christmas decorations, and there were all sorts of other things that were obviously of great value to the families and the patients, but not particularly desired by the health professionals. And in the end, there's only so many pens that you can actually write with.
Thanks for that thought-provoking comment. Now, the next question we have is, we've talked a lot about corruption at the front lines. Do any of the panelists have thoughts about how we can tackle corruption focused on the highest levels of national authority?
I wish we did, and I think this is partly the need to talk about these things in international fora, and to challenge. One of the what I think is very important, and in much of the work that we've done here and in other areas, particularly about the right to health and unmet need, less so in corruption, but have argued very strongly for the role of civil society and shadow reports and holding governments to account. Now, you'll recall that I framed my presentation in the SDGs, and we're arguing very strongly that to achieve the SDGs, and particularly the universal health coverage one, you have to root out corruption. Governments are accountable for their progress towards the SDGs. So that is an opportunity for us and for those who are monitoring the SDGs, and for the academics and civil society who are tracking progress, to actually keep calling it out. And working with groups like Transparency International. Now, there, I think I said, also picked up SDG 17, which is about partnership. And that's where I think we in public health, just in the same way, Dina and I have done a lot of work over the years looking at the law on public health and going back some time, working on the way in which legislation about counterfeit medicines and counterfeit medical devices and even safety things like vehicle components and so on, we need to work with law enforcement. And in a positive way, because of course law enforcement can often be corrupt too. And so we need to look at sectors like that. We definitely need to look at the international banking system. We need to look at the fact that there are regimes and there are territories in the world that are tax havens. The Panama Papers, for example, I think is a very legitimate area of research for public health research and health systems researchers to be looking through resources like the Panama Papers in the same way that we look through the tobacco industry documents at the University of California at San Francisco, and we look at the corporate determinants of health. And I think as we look at the role of the large corporations in health, in the tobacco and the alcohol and the gambling and the chemical industries, we also now need to extend that work into the banking sector as well, to look at the way in which some of the actions of some of the less responsible banks, and more importantly, some of the administrations like some of the British overseas territories and states like South Dakota and Delaware are complicit in these things.
Great. Now, I'm conscious we're running out of time. We have a few more questions I'd like to try and get through. So this is for Martin or Dina. Do you think we need top-level political support in order to act effectively on corruption? And if you agree with that statement, do you have an example of a country where the tone from the top has resulted in significant improvements in efforts to address corruption?
Well, I think yes, we do, and we're just trying to think of an example of I mean, there are countries that have taken action at the top and leadership in health policy generally. I mean, one thinks of countries like Costa Rica historically, but ones that have. But if there wasn't really in corruption, it was more about taking a stance. Have politicians? Lots of politicians start off trying to root out corruption, but they often then, unfortunately, give up. I think you've raised a very good point.
So Tanzania right now, Tanzania has announced the mandate of the current government is really about reducing corruption, and there's been a lot of publicity around monitoring contracts of public employees, permits, various. So again, I don't want to comment because we haven't looked at that, but there are certain sort of governments who are starting now, but it's really difficult to say. For example, in China, there's been a lot of push by governments because the money amassed in the health system through people just hoarding money has actually been problematic in terms of fiscally. So again, the government has been explicit, but to what extent that was followed by actions? I mean, I saw another question. I just wanted to say there are a lot of governments who talk about transparency and accountability, and there's been research on actually getting, for example, complaints by people. Even Indonesia implemented a nationwide program. Every single person from a simple phone can deposit a complaint. Bangladesh has public hearings even in villages. A huge amount of NGOs. We work with some of those collecting information. What we can hardly say happens is, what do they do with this information? What can we actually do? And I think that's the problem of a lot of very sort of successful initiatives, transparency and accountability. But what we don't see is the follow-up. And even in Bangladesh, they told us there is official data online on absenteeism of doctors in every single facility because of the biometric monitoring. But this doesn't really link to anything. It doesn't translate into any penalties. It doesn't translate to any investigation or management follow-up. So that's, I think, where we don't have the information. We do have information how to get the problem, but not what to do about it.
So I'm very conscious we're running short on time. So I'll just take one more question. And the questioner says, surprised to hear there's hardly any research on corruption when for years we've been using arguments for better PFM, transparency, governance, saying one of the benefits is to reduce corruption as well as increase efficiency. Have we been saying this without evidence?
Well, the question is, do we actually need evidence? I mean, there are some things that are self-evident that are a good thing. Let's turn it round and say, is bad governance something that we should be aiming towards? So I think the challenge is not whether bad governance is, if we were to do a randomized controlled trial between good governance and bad governance, would that be sensible? I don't think it would be. I think we know that intrinsically it will be good, but quite how good it will be and how it will benefit and who will benefit from it are the important questions, and how do you actually make a difference? Yeah, I think we can, even from a simple moral point of view, we can just say corruption is not a good thing to do. I don't think we need. It's a bit like the question of why have there been no randomized controlled trials of jumping out of aircraft with parachutes, of which there have been none. I don't actually think we need them. That was a paper in the BMJ, by the way.
This is Eleanor just coming in as well. I think it's really important to look at the evidence that we have, and I think if you go back and look, especially in health, in the Cochrane review, we have very little evidence in terms of what works as anti-corruption strategies, and really the push for us in terms of researchers are to find anti-corruption strategies that work. And so I think it is surprising when you look at the evidence that has been done on good governance and think about corruption, that actually we don't really have these strategies that clearly work. And I think there was an assumption that the sort of broad transparency, accountability interventions would have a major impact on corruption. And if you read the recent Transparency International report, and then you go back and look at that Cochrane review, it makes for really quite stark reading.
So I'm really sorry, but we're going to have to call a halt to the webinar today. But never fear, we are going to have more webinars on this topic. So if your question didn't get asked today, please hold it and participate in our next webinar and ask it then. So I'm going to give the last word to Dina, just to wrap things up and talk about next steps.
Thank you very much. This has been a really interesting conversation. I can see a lot of other questions in the comments box. Watch this space. We'll continue to work on this. To summarize, I think in terms of the priority for research, what we need a lot more. So we have a lot of research on how to improve transparency and accountability as such, but what we don't know is about outcomes, and also we don't understand the drivers. We just did a big review, so understanding the individual drivers, but also the collective or group drivers, the political structures that are underpinning corruption and irregularities at national level. And it could be at meso level, at micro level and macro level, but starting even at some of the practice, understanding the determinants of practices at micro level, at the front line, it gives us a lot of information of practical strategies that could be immediately implemented, possibly, while the strategies, if we look at meso and macro level, these are more long-term sort of plans. So they all have to be together, different type of study, different type of research. But again, I want to emphasize what we talked a lot about. We're looking at formal systems and accountability systems, but there are informal systems. There are informal agreements and ways people work. We need to learn to tap a little bit more into that and understand that. And then there are, of course, specific risk, red flags, or places in the health systems where structures and processes are designed in a way that really creates spaces of corruption. We can look at those and be aware of those. But finally, we need to work to change beliefs, to change traditions, to change social norms. And we have 30 years from the fall of the Berlin Wall. I'm coming from behind the Berlin Wall, from a country in Eastern Europe, and I would say practices change and views change. You will be surprised how quickly, even in low-income countries, people become less tolerant of practices which were seen traditionally as cultural. For example, gift giving. Gift giving in many places is declining once people have an alternative. And we have to be very careful and really understand, well, what is expression of culture or relationships, social relationships, or what is enforced because of problems in the health systems. So thank you very much.
Thank you.
And in terms of next steps, we are continuing with our work on this, we are proposing, and we will try to organize a session at the Health Systems Research Conference, Health Systems Global Symposium in Dubai next November, next year. We are planning regular webinars on different topics to try to create and to get a group together, to work together and to try to follow up on some of the themes. But in the meanwhile, please contact us or David and Aurelie, and we are trying to really build a repository of studies, materials, systematic reviews, and really try to get a interest group together.
Thanks very much, Dina. So thanks to everybody for their participation today. Thanks in particular to our presenters. We're very sorry about the technological problems we had with the first presentation. We will make sure that all of the presentations and a recording of the webinar today are made available on the Health System Governance Collaborative website. So thanks to us in Geneva, and over and out.
Thank you.
Thank you.
Thank you very much.